So on 14th of February, as people were discussing love, as the Energy and Petroleum Regulatory Authority was considering the price of fuel, others in the profession of medicine were having another separate conversation. And this was being led by the Group CEO of Amref Health Africa, Dr. Githinji Gitahi. A press release released on that day starts this way. Is it time to reduce mask mandates and accelerate vaccine access in Africa? My answer is yes. Dr. Gitahi says all signs indicate that we may be moving from the pandemic to the endemic phase of COVID-19, and the tools used for each phase, and indeed even between phases, are different. Masks, if properly worn, have contributed significantly to reducing the speed of transmission and protecting people and health systems, not eliminating the virus effect, which only changes by host community or change in the virus itself through mutation, like seen with the Omicron variant's dramatic infection rate, but much lower severity. As such, when the risk of transmission is as low as it is now in many countries, we need to rethink current policy to adapt it to the current situation by removing mandatory masks everywhere to, for example, recommending their use indoors, in public, and accelerating vaccination access for all. Then he goes on now to discuss why. Now, of course, when you hear that, you're like, all right, okay. So are we saying that we start, looking back and saying, globally, there are three things that the WHO has told us. Best ways to avoid to keep yourself safe from COVID. Observe distance, wash your hands regularly, and wear a mask whenever in public. Now, when this conversation then comes up, are we saying, okay, let's now start looking at, globally we are seeing those conversations taking place, remove some of these mandates. Is it about time that we had the same conversation in this country? Is it good or is it not good? Time to have a conversation. Dr. Githinji Gitahi joins us now on video link. He is also online. Good morning, Dr.
Good morning, and how are you all?
Very well.
We are well, thank you.
Thank you very much for joining us. Although it would have been nice to have you in the studio, but we understand where you are. Doc, this one has raised a very big one. And even before we continue, let me just say, yes, in addition to you being the Group CEO of Amref Africa, you also sit on the board of Africa CDC, and you're also sitting on the commission, the African COVID-19 Response Commission. So when it comes to matters of COVID-19, you're right there in the thick of things in looking at how the continent is dealing with the COVID-19 pandemic. So you are very well informed. And so, therefore, when you say, look at how things are going globally, we may be moving from pandemic to endemic phase, and let's start considering the removal of some of these mandates. Please take us through the why. Why should we start having this conversation now?
Well, there are several reasons why we should have this conversation. Most importantly, is that every single tool we have used in managing the pandemic has been used when it is most effective. When you put on curfews, for example, you put curfews when there is a high rate of positivity, and therefore the chance of being infected is very high. Number two, you put curfews when there are many patients going to the hospital and the health system is likely to be overwhelmed, because then you can't take care of people who need oxygen, who need beds. These are the reasons, and there's the data that guides some of these decisions. A mask is also a tool of control of the pandemic, and therefore it should not be assumed that it is an eternal tool. It should be used when it is necessary. You remember, last year I also talked about the curfew that should be reviewed because the cases had come down. And I did that because we had used the curfew for almost 18 months, irrespective of the peak of the infection. It was a constant tool, and it was finally reviewed because it has an impact on livelihood. It has an impact on people's social and economic lives. Not that it's a bad tool, but you use it when it is most effective. Masks are the same. You use them when they are most effective because they have a cost. Masks cost 50 shillings to 70 shillings. Many people cannot afford this, so they have to overuse the mask, which also means that the effectiveness of the mask does not apply, because then it's used over time and therefore is not protecting the individual. The other thing is that there's a fine. There's a judicial fine if you don't wear the mask, which then puts people at a great disadvantage. And also, there's a cost to the environment because of disposal. So the question then to ask is, because this tool has cost, when should we use it? And we should use it when there is a high infectivity. Right now, we have 1 case in 200, 0.5% positivity. Shouldn't we then lift the mandatory wearing of masks in public and keep it close and say, if the cases start rising, we will reinstitute the policy instead of just having it at a constant cost to people and to the environment? This is the thinking that I'm sharing.
Dr. Ari, even as you say this, those that put this mask mandate in place, I want to assume that when they did this, there was some kind of thinking, or at least it was fueled by some kind of information. To then remove this mandate also, as you're saying, must then be fueled with information. Why would it be that this would not be considered? Seeing the positivity rate drop from when we were teetering at 30% for a very long time, and then now under 1%, shouldn't it then be obvious that certain things need to happen when you've seen it constantly at 1% over the last 90 days, for example? Shouldn't it be that it's almost obvious that that decision be made? Because we're dealing with experts in their field who make these decisions.
You know, policy decisions are as political as they are scientific. This is what we must remember, that every policy decision is both scientific and political, because it affects lives, it affects people. This is why curfew was removed. This is why the government did not leave the curfew until let the pandemic disappear and then get back to the curfew, because there was pressure from people. And therefore, we must always remind the policymakers that actually this is time to have the debate. And this is why my paper or my press release said it is time to review the mask mandates. To review means that the scientists in the Ministry of Health can sit down and say, it is time to review. So based on the data, we are going to make sure that it's not mandatory anymore to wear when you are general public, but in the particular instances, like if you're going into a place where you're going to be indoors for a long time, then we may say that it is mandatory, and the implementation is by the outlet. You've seen there's a mandate on vaccine certificate, but how is the implementation? It is actually being done outlet by outlet. It's not. There's no one going around the street saying, "Can you show us your vaccine certificate?" So it is actually the mandate that needs to be reviewed in terms of implementation. Right now, if you want to go and arrest a woman in Busia in the market for not wearing a mask and take her to court and charge her 20,000, you can, because the law provides for it. These are the things that need to be reviewed so that we don't put an extreme burden on the individuals when actually the effectiveness of the mask is at the lowest level, because you are unlikely to meet somebody who is positive, because the positivity rate is very low. So it is science. And that's why I'm raising the debate. That's all I'm doing, raising the debate.
Right.
And not for Kenya only, for across the continent.
Dr. Ari, why would you say that this positivity rate has gone to the point where it is now? What has happened? And while asking this, I'm also asking myself, so what would cause the opposite to occur? What would raise the positivity rate again?
So there are many factors. If you look at from the time we started, there have been waves, as we call them. There are highs and lows, because what happens with the viruses is that they actually started clusters, okay? So they started clusters. You have a cluster of susceptible people. That word is important, susceptible, meaning people who are probably not vaccinated, people who probably have low immunity. So it is easy for the virus to move from one person to the other. There are many people, by the way, who come in contact with the virus, but because of host immunity or host condition, the virus doesn't survive and just doesn't get through the nose or the mouth, and therefore is dissipated through what we call antibodies or whatever. Let's go to science. But there are people who are more likely to get infected. It's not much like HIV. In HIV, you know, there are discordant couples. There are people who live with each other. One is positive, the other one is negative. It is science. It is host conditions and also the infectivity of the virus itself. So when you see these waves, it means that there is a highly infectious virus that has infected somebody who is close to a subset of people who are also likely to be infected, and therefore it picks up in a what you call a geometric version, and that creates a rise. But when this population or subset is exhausted, then it starts to drop. But that doesn't mean that there is no other population that's susceptible. It goes and then picks another susceptible population. This is why waves happen. This is why they happen. So this particular one of Omicron was very high because the infectiousness of the virus was almost 10 times the previous one, meaning that even people are less likely to be infected by the other one, could not avoid being infected by this one. So the peak rose, but we also saw that there were fewer people who got severe disease and got admitted, which means that a lot of people got host immunity through this exposure without going to the hospital. And therefore, this is probably now starting to reach the end of the pandemic because we've seen a lot of people have been infected, people are getting vaccinated. What we don't know is how long this immunity will last. So we have to wait and see. But we know that it is coming off the cliff because it has infected the subset available. But that doesn't mean that the immunity will not go, and then maybe in future that will happen again. But we don't know how long. But we have to follow science in terms of the tools we use at different times.
Even as you say this, Doc, so again, there's so much that's unpredictable about this. So the question is, if we say, let's ease up on some of these mandates, and then something happens later, we're not saying have it as a position of eternity, right? If something happens later, then you can reintroduce. Is that what we're saying, essentially? That we see that the positivity rate is so low today, but then something could happen tomorrow, you know, knock on wood, but then there is another variant that comes about. Then we can say, because we've seen this and we see that there may be a rise in infections in the near future, then you can reintroduce the wearing of masks, for example. That's part one of the question. And then part two is that you say, releasing some of these measures, maybe masks don't need to be worn in public. Where then should they be worn, according to what you're thinking right now?
So, number one is that all medical tools we use, not only the masks for COVID, when we are looking at vaccination for children, we look at effectiveness and convenience. And then you say this vaccine, because everything you use has some negative effect, whether it's a vaccine, whether you're taking a painkiller, everything has something that you can call an adverse event because it can happen in 1 or 2 people out of a million, doesn't matter. So when you're doing a medical intervention, you look at when it is most effective because you want to make sure that the benefit outweighs the risk, okay? So when you're giving measles vaccine to children, or you're giving HPV vaccine for young girls to avoid getting cervical cancer, or indeed you're giving children a malaria vaccine, which is a new one, you must always ask yourself, at what time in their age is it most effective? If you didn't ask that question, you would say, let's just give all children so that we just have a shotgun strategy, just in case. But we don't do that. So we shouldn't do that with tools like masks. We should say, because they also have an impact on individuals because of the cost and also the harassment and human rights because of the fine that's put on them. And also, people can make a decision not to go to work or to go to hospital because they don't have a mask. And they say, until I get money for a mask, I'll not seek medical care. Or I'll not go to work. So their impact. So use it when it's most effective. And that applies to all tools, not just masks. And that applies to curfew as well. On this other question that you're asking, where should they be used? This is what we need to look at. We need to look at the data available. We need to look at, for example, now we're saying we have 28 cases out of 600 tests. Where did these 28 come from? Are they from particular communities? Are they from particular counties? When you trace back, did they arise from particular situations? Then in those situations, you say, if 50% of these 28 cases are all related to a church event, then you say, in church, because there is still a risk, then we advise people to wear masks. What if all these cases actually came up in a particular county? Then you say, in this county, please wear masks for this period. That is how we follow science. So we need to analyze that data to decide where the masks should still be mandatory and in other places, discretionary. So we are not saying remove them completely. I might decide I'm 86 and I'm going to a market, I'll wear my mask because I know there's a high risk. That's what we are saying, or that's what I am saying. That's my opinion.
Yeah.
You say this is, going by even what the government has done previously. There was a nighttime curfew. The nighttime curfew was lifted. There was restriction on the number of people who would, for example, board public transport. That was also lifted. So if we say, let's review the mask mandate, what else can we also review?
Actually, I would say right now, we've fairly reviewed most of the restrictions. You have seen that travel has now been, of course, restrictions have been lifted. So we can say that the only things that are remaining, the constant hygiene, like hand washing, that is constant. And we do that not for COVID only. You do that for child pneumonia, you do that for diarrhea. So those should stay. Wash your hands when you're entering a place. And that I love. That's one of the biggest benefits of this pandemic, that our sanitation and hygiene is going to improve, and our supply of water and our recognition and conscience about sanitation. But if you look at the only other mandates that are remaining, it is masks. But we know that the permanent solution to this pandemic and any other is vaccination. That we know that when you vaccinate people, then that is the permanent tool, because then you create immunity in their bodies, and therefore, whether there is a wave or not, their bodies are protected. And that's why I'm saying in my press release that vaccination mandates, not mandatory vaccination. These two are different. Vaccination mandates must continue, must be implemented, but we must also resolve, if you look at that press release, you must also resolve convenient access, because there is a view that the reason we are not achieving vaccination numbers is because people are hesitant. In my experience, going out to the counties and to other countries, the challenge is people don't have convenient access. If you find somebody who leaves their house at 5 a.m. to go to the wholesale market, buy vegetables, then go and queue them and sell until 6. When do they get vaccinated? If all vaccination centers open at 10, close at 4, and don't open on Saturday and Sunday, then we say people don't want to be vaccinated. So these are the things we need. We need to focus our efforts to the tools that are of the day. And that is where we should put our efforts, not putting our efforts on. And you see, let me just say, you've seen the political rallies. How many people have been charged 20,000 in a political rally? Zero. So we need to use science the way it should be used and stop overburdening communities when we don't have to. But when we have to, we bring the masks back and make them mandatory.
You speak of a matter of cost. Now, there's a cost, of course, to transporters, because they are required, especially those that are crossing borders, to have vaccination certificates and also PCR test certificates. Should this also be reviewed? I mean, does it really make sense to continue saying that if you're crossing over from Kenya into Uganda, transporting goods, you must produce a certificate showing that you're negative?
This is another burden, and you've raised an important point. I think the question here is, what are the the differential positivities between countries? Okay. If we need to look at that. If you're going to Uganda or Tanzania, what's the positivity rate in those different countries? Number one. Number two is we do what we call genetic sequencing or gene sequencing. So you can tell what variants are in one country that are not in the other country. So again, countries need to compare data and say, are we carrying exactly the same gene sequences? So that then there is no danger to each country. Or are we actually having different gene sequences of this virus? If you're having different gene sequences, then we must limit the transfer of these gene sequences country to country, and therefore we must do PCR testing. So that's, again, a scientific decision. The next question is, what is the risk of transmission? Then finally, what is the vaccination rate country to country? You have seen countries now saying, if you're vaccinated, we don't need a PCR test from you. So this is how we need to determine, and therefore countries need to be together. There is what we call international health regulations that were put together in 2015 and in 2005, and these regulations are the ones that guide how countries relate to each other in terms of what they demand from each other and how they correlate across borders. So, but sometimes we tend to actually put policies and then there's no review. They just keep on going and going and ongoing. And unless there is public pressure, like on curfew, and now there needs to be public pressure on, or scientific pressure on masks and on testing, so that then policymakers take a time to review them. And when they review and the data says we need to continue, then we must continue. But when the data says it's time to review, then we review. But we shouldn't just assume that they should continue forever.
Okay. I'm looking at, when we're talking about then international agreements between country to country, getting information from what another country is doing and then comparing notes on the same. Now, here we are on a continent looking at Kenya, where, to be honest, for the last 2.5 going to 3 years of this pandemic, that the numbers are still relatively low. I mean, can be looked as that COVID has not penetrated as it has in other parts of the world, which is true. We cannot run away from that. So, shouldn't there be then a different set of rules that governs how we deal with it here in as much as we're seeing other countries doing different things, shouldn't the fact that because the numbers have been so low here, then change the way in which we operate in terms of mandates on several things?
So low is relative. Low is quite relative. And let me explain this. That actually the reason, assuming that the COVID virus did not have severity of disease and therefore people got infected but they didn't end up in hospital, you do not need any mandate, you do not need any curfew, you don't need lockdowns, because you just tell people when you get infected, go home, take some water, and you're fine. The reason that these restrictions are put is that the guide is largely to protect lives and the health systems, or health systems and lives. So even if the cases that are ending up in the hospital or the recorded deaths are not as high as they are in other countries, you have to look at the capacity of your health system. So the moment you get a health system, because probably when we started, you will remember, we had barely 500 ICU beds across the country. Now, if you have 500 beds and then you need 1,000 people in those beds, then it doesn't matter that your number is not as high as Italy, but it means that you have to do something to reduce the number of people requiring ICU from increasing. And how do you do that? By reducing the force of infection. How do you do that? Telling people to stay at home, to wear masks, and to put curfew until you know that actually the numbers needing ICU can be taken care of. So that's what I'm saying. Low is relative, and it has to depend on how strong your health system is to take care of the numbers that need your care when they need it and in a timely manner.
Dr. Aria, the African COVID-19 Response Commission, what exactly do you do? What does this commission do?
So this commission was put together by the African Union through the chairmanship of President Cyril Ramaphosa. You will remember that when the pandemic hit Africa, President Ramaphosa was the chair of the African Union at that point. And he, because of his determination, he did work a lot with Africa Centers for Disease Control to ensure there was a continental response. You will remember that for the first time, Africa was took concerted efforts together. During Ebola, there was a lot of disjointed action across the continent. But during this time, because of the presence of Africa CDC and his chairmanship, there was concerted effort. Countries worked together. There were a lot of task forces created. Countries were meeting every week. Heads of states were meeting to ensure, for example, to fight for PPEs, to coordinate PPEs in the country, coordinate vaccines, coordinate response. So because of this success, actually Africa's response, as we discussed earlier, was fairly good. And therefore, even after he left the chairmanship, there was a feeling that his experience during this time was still needed by African Union. So he was appointed the Africa COVID-19 champion. And he felt that he could not execute that mandate without professionals and experts across Africa assisting him. So he created a commission of 15 people. That's the commission I sit on. And this commission is charged with, most importantly, one, looking at continuity of supply of medical commodities and ensuring security of commodities across the continent, not only for this pandemic, but any future one. So the commission has a big wing of looking at vaccine production in the continent, vaccine markets, and how vaccines can actually be available to the continent, not only for COVID, but also for others. Because I don't know whether you know that 99% of all vaccines used in Africa are imported. So there's a big agenda to make sure, how do we ensure this changes? Number two is what is called the Africa recovery. We need social and economic recovery during and post the pandemic. That is the working group that I chair on how to ensure Africa's recovery. And we do know that if you build a health system, then you can support the recovery, social and economic recovery, because then people can go to work. Children who are healthy go to school, and adults who are healthy go to earn. So I am chairing the working group on Africa's recovery and working with Ramaphosa and African Union to ensure we do have a strong health system, including building the Africa Task Force on Health Workforce, building the Africa Pandemic Preparedness Authority to ensure we are never in this place again in future. And then, of course, there is a working group on resource mobilization to ensure we have money to do this work, and the working group of gender to ensure that actually any future policies are gender responsive and they don't inordinately affect women. You will remember during curfew, women couldn't go to deliver because curfew starts at 7, and there was no provision for women to transition from home when they're in labor to go to the hospital. We should never have those situations again. So these are the issues that we are looking at, and whenever we make a policy brief or direction, Then President Ramaphosa takes it to the African Union, and then the heads of state debate it and either adopt it or ask to go back to the Commission. 2 weeks ago, when there was the Africa Summit, we got the 2 treaties and several treaties approved or endorsed by the African Union, including the formation of the Africa Pandemic Preparedness and Response Authority to be under the Africa CDC, and also the formation of the Africa Health Workforce Task, which is going to look at how we ensure the continent has adequate health workers for ensuring that we have an adequate response in future.
What have you done so far to make sure that we get vaccines, especially vaccine production within the continent? For COVID, starting with COVID.
Yeah, so there are several things. Number one is that, of course, for now, we need vaccines now. So even as we talk about future production of COVID vaccines in Africa, we must ensure there is justice. And that's why we've been making noise, and we have made a lot of noise and called out those who are colonizing Africa by holding vaccines and then delivering them to Africa when they are near expiry. We have been very loud on this, and we have been very candid on it. The next thing is that we cannot always rely on our neighbors and rely on goodwill. So we have to build capacity in the continent. But my voice has been that Africa must not be seen to be building capacity for vaccination for Africa only. Because then people will say, oh, you are manufacturing only for Africa, then we are not worried about your quality. You can do whatever bad quality you want. You can do whatever you want. Africa must look at manufacturing vaccines for the world, and therefore it can become a center of excellence, uses its skills and labor market to manufacture vaccines for the world. So there has been formation of the Partnership for Africa Vaccine Manufacturing by Africa Centers for Disease Control. I am an advisor on that PAVM, and what we are looking at is how do we actually increase the current 1% of vaccine manufactured in Africa to 60% within 10 years, and then looking at what technology is going to be needed and where does that technology come from. So we are doing technology transfer with other countries that are ahead of us. Number 3 is what labor is needed, what human resources are needed, and how do we train them? How do we create hubs of knowledge? And finally, who manufactures? Because you can't tell every single country. If you go to India and say we are improving vaccine manufacturing, it's 1 billion people in one market. In Africa, we have 1 billion people or plus in 54, 55 markets. So you can't tell all countries, this is a strategy, please go manufacture, because then what do you do with all those vaccines? You end up with white elephants. So we're also looking at what are the strategic sites for manufacturing of which vaccine, and that is where we are right now. But we've engaged also the people who purchase vaccines, we've engaged the people who have the knowledge, we've engaged member states in this conversation, and that plan is shaping up.
Do you think that it would be necessary to then demarcate the continent, and I'm saying this as separately from what happens with the rest of the world because of some of these issues that we see that have dogged us for the longest time, to be able to be bold enough to have the conversation and say, well, look, you know what, we can do this for ourselves. The other day we saw that South Africa might get this provisional status to then start to develop and produce, and that is essentially something that could go throughout the rest of the continent. Is it about time, though, that instead of trying to join the table and then sit under the table and get what falls off from the meal, be bold enough to start having the conversations to say, look, we can do this for ourselves and we don't really need the permission of, the quote unquote big companies and bigger countries who have previously controlled the conversation?
Good conversation. And we have to realize that we have several constraints. If you remember the start of the pandemic, Pfizer and Moderna and AstraZeneca was significantly funded by their public taxes to do the research and development for the vaccine. Because what we see is the end product. There is a huge investment in research and development to ensure that the vaccine is effective and safe. Now, how much money does Africa have to actually support research and development? And is there a budget called Africa, or is that national member states budget? Is there a framework we can create that member states can actually contribute to a research and development fund that is held at Africa Centers for Disease Control at Africa Union that can be able to fund public research and development to actually prepare Africa for the next pandemic? So these are questions we have to ask, and that question is being asked. Number 2 is that after you've done this research and development, where do you produce the vaccines? You need to produce them where already capacity exists. We know that capacity exists in several countries. South Africa already has capacity for manufacturing vaccines. Morocco has, Algeria, Senegal has, Kenya is developing. I've seen Uganda developing. We have to start asking this question and say, let us go where the capacity is and then finance the research and development. It is so, I think the US funded Moderna and Pfizer almost $1.5 billion. That is a conversation that needs to be had, because you can't expect, SpiceFM manufacturing company to go look for $1 billion or even 500 million shillings to do research and development. And how does that money come back? Because vaccines are public goods. They are not just sold in the market.
Sure.
So there is a financing conversation. There is allocation, what you're calling, allocation of distribution hubs that is being had, and countries have already been identified. And after that, it is shaping the market. Because even if you manufacture vaccines in Kenya, Morocco, and Algeria, then what about if the other countries don't buy them? Then what do they do with them? Because they can't manufacture only for their country.
Yeah.
So there's also the market shaping conversation. It's not an easy conversation to have.
Dr. Gitahi, thank you very much for speaking to us this morning, and wish you all the best.
Thank you very much for having me.
Dr. Githinji Gitahi is the Group CEO of Amref Health Africa, also sits on the board of Africa CDC, is also among the experts who are in the Africa COVID-19 Response Commission. He says it's time to review the mask mandates, not only in Kenya, but in many countries across Africa, because of the level of positivity that we are seeing with COVID-19.
This is the Situation Room, the only way to start your day.